I'm going to be starting today's presentation. My name is Nancy Gessner. I'm a public health nurse with the Horizon Health Network and have been for, I hate to admit, but over 25 years that I've been working with public health under different organizations, I guess. Since just a little bit about the project, I am the public health nurse who is representing other public health nurses who also were part of this working group, not just through Horizon Public Health, but through Vitalité Public Health as well. Just a little bit about our program. Since 2017, public health section programs that are under the RHAs have moved to a mandate of functioning from a population health promotion perspective, with an overall goal of improving the sexual health of New Brunswickers across the lifespan. So some of the things that we would look at in those goals are decreasing the rates of sexually transmitted and bloodborne infections over the population, increasing the number of pregnancies that are seen to be healthy and planned, and increasing indicators around healthy sexuality and healthy sexual relationships. In 2017 and 2018, through Horizon Sexual Health Program, we went through a strategic plan renewal. And through that time period, we did an extensive review of the New Brunswick stats around sexual health. We did an extensive review of the literature, the pertinent data that was out there. And we also conducted many stakeholder interviews to look at what the needs were and what some potential gaps in service were in the Horizon catchment area across the province. And I believe that Vitalité Public Health, because they had just transitioned to our new way of doing business, were also doing similar work in their area. Current project is one that really stemmed from that time period and the work that we have done. I want to just put a huge thank you out to Samantha Fowler and her team with MSSU for their support and guidance and perseverance throughout this project. We have experienced many stops and starts due to the things that have been going on in our climate with public health and public health needing to respond to. So we started out with a significant measles outbreak in 2019 in southern New Brunswick, and that took some of our public health staff to respond to that. Certainly really slowed up our project. And then we began dealing with a little thing called COVID, and certainly that has been a real thorn in our side as far as responding to other things that public health typically does. So when we have a public health crisis, it certainly is all hands on deck. So that's been our life for the last, obviously, about year and a half almost. So getting to this final report stage has certainly been a feat, but here we are and ready to move on, hopefully soon. Okay, so Sam, if you want to move to the next slide. So some of the data that we found when we explored the research literature to support this project. Certainly, we're seeing some high rates of sexually transmitted infections and unplanned pregnancy amongst the youth in New Brunswick. Around unplanned pregnancy, that has certainly improved drastically over the last decade or two. However, we are still seeing a rate of unplanned pregnancy within that 15 to 19-year-old population still being significantly above the Canadian average. So that's disturbing. That certainly is an indicator of overall health in a community. So we really want to attempt to continue to improve that. As far as STBBI, sexually transmitted and bloodborne infections, we still see highest incidence rates in our most commonly seen sexually transmitted infections, those being chlamydia and gonorrhea amongst our youth. So that 15 to 29-year-old population. So again, that's disturbing. We are also seeing an account of the majority, so 66% of sexual violations being reported by police being reported to police rather, occurring in the 18 and under population in New Brunswick. And according to the New Brunswick Health Council Student Wellness Survey, the last survey that was done by that group, 12% of boys and 18% of girls in that grade 6 to 12 age group were reporting being exposed to dating violence over the previous year. So those are very alarming and disturbing statistics that may be indicative of lack of knowledge around healthy sexual health practices, maybe, some lack of awareness around what true consent is, about child and youth personal safety, and a lack of understanding about healthy relationship characteristics. So those are really important things that we want to improve upon if, we're really truly helping to improve the sexual health of New Brunswickers. According to some research as well, we also are seeing a large need for sexual health education in New Brunswick due to a considerable variation in the context and scope of sexual health education received among individuals, schools, and communities across the province. Therefore, parents, we really suggest and talk about the fact that they should never rely solely on school-based programs for their children's sexual health education. The research also shows that positive sexual health communication between parents and their children and adolescents is an important determining factor in the development of healthy sexual health and healthy sexual health behavior amongst that adolescents population. So we don't, we certainly would encourage that parents are having, they're approachable in their household, that they are having conversations around sexual health, not just those short questions short conversations responding to questions for the children who ask questions, because certainly many of them are not asking questions within their household. So having a viewpoint from the child and adolescent perspective that this household is an approachable household, that they're approachable parents as far as those difficult topics, and not just around sexual health, but other things that are difficult topics to address in the household. One of the phrases that I've used many times during my years working in the sexual health program, especially when I'm talking to parents and care providers about sexual health and their children, is that it's really important that this is not seen as just being the talk, but that this is seen as a lifetime of talks, as it is with all subjects and conversations around that difficult stuff. Okay, some of the barriers that have been identified in the research around parents and, reasons that maybe they're not having these conversations. We have, and other research has identified limited sexual health knowledge, potentially believing that children and adolescents are not ready to have discussions about sexual health topics, may be a barrier, or that embarrassment or discomfort around talking about sexual health topics and conversation. Researchers have also found that parents' sexual health education practices are often influenced by what was taught to them in their households as children. It may also be influenced by their gender, their ethnicity, and certainly possibly by their political and religious beliefs. So many research studies have also demonstrated that promising effects of interventions to alleviate these barriers have really helped in increasing knowledge and discomfort, with hopes that that would also increase the quantity and quality of sexual health communication within households. We certainly identified a need for resources, and this mostly came up during our conversations with those other community stakeholders when we were doing those interviews over and over again. We heard from other people who were working with families, who were working around sexual health topics, that there was a lack of resources, and maybe not necessarily a lack of resources, but not knowing where to go to find appropriate resources, maybe a need for resources with more of a flair for our own communities. So that was certainly identified by many stakeholders, and many of those stakeholders were actually parents. We had lots of conversations with those parents as we move forward. Also, improving sexual health education in communities was identified in Horizon's top 20 regional priorities that was outlined in the Broadening Our Focus document that was released by Horizon Population Health Department back a couple of years ago, I guess now. So all of this leads to the present study that Samantha is going to outline. We felt we needed to go to our current population of parents, step parents, and guardians in the province of New Brunswick to get from them what it is that they really need and to help support them in their role as being the primary sexual health educator of their children, with hopes that the information that we gleaned from this research study would help to develop or adapt resources that are already available to support and meet their needs in that role of being primary sexual health educators of their children and adolescents. So I'm now going to pass on along to Samantha, who will review the study and review the analysis of the results that were found.
Hi there, I had a technical difficulty for a moment. I think I am here now. So it's with this idea. Am I here now? Do you have my slides? No slides? Okay, we will try that again. All right. All good now?
Yes, we are. Thanks.
All right, so I don't know where you lost me at. I got kicked out momentarily, but I was in the process of introducing myself. So I'm Samantha Fowler, the Clinical Research Manager of the Maritime Spore Support Unit in St. John, and we're embedded in the Office of Research Services in Horizon Health Network. And it was through that office that Nancy reached out to us, and together we developed and implemented this Ask Me Anything survey. And in this survey, we surveyed 5,462 parents, step-parents, and guardians from across New Brunswick. The majority of the participants completed the survey in English and were women, heterosexual or straight, were born in Canada, and were of North American, other, or European descent. And the mean age of the sample was 39 years. And while this doesn't sound particularly diverse, it is worth noting that given the size of our sample, we did have representation from many demographic groups, including 1,235 participants who completed the survey in French, 290 LGBTQ2+ participants, 269 born outside of Canada, and 451 other ethnicities, most notably Indigenous participants who comprised 5.7% of the sample. On average, participants reported having 2 children, and the mean number of males and females was equal. Nearly a fifth of participants indicated that they had children with diverse learning needs, most commonly ADHD, a learning disability, or autism spectrum disorder. Participants were recruited across Horizon and Vitalité health networks, school districts, and community partners between December 2019 and March of 2020 through relevant email lists, social media accounts, posters, and handout cards. And these interested individuals were given a link to Opinio, an online survey platform, to provide informed consent and complete the online survey. For participants who were unwilling or unable to complete the questionnaires online, they were able to get a paper copy while at the office of a community partner or by calling a designated public health clinic to obtain a paper questionnaire by mail. And this questionnaire contained 41 items assessing participants' demographic characteristics, current sexual health education practices, and sexual health education needs. Jumping right into the results of the study revealed that the vast majority of participants believe that parents and guardians are primarily responsible for their children's sexual health education. Although many participants felt that other parties do share the responsibility, most notably teachers and healthcare providers. Most participants in the study agreed that they have sufficient knowledge to educate their children about sexual health. Similarly, the majority of participants in the study reported that they were comfortable discussing sexual health with their children. There was considerable variation with regard to the frequency of sexual health communication, but most participants endorsed a moderate amount of communication, such as a few times or quite often. Notably, some of the participants who indicated they never spoke to their children about sexual health reported that their children were too young to need this information. Regarding their satisfaction with existing resources, many participants neither agreed nor disagreed that the available sexual health education resources met their children's needs. Overall, though, more participants were satisfied with the resources than dissatisfied. This result is somewhat surprising given reports by community stakeholders indicating that there is a lack of available resources to support parents in their role as primary sexual health educators. Nevertheless, there is considerable room for improvement of the resources, as evidenced by the over 500 participants who did not feel that the current resources met their needs. Likewise, many participants also indicated that they were neither satisfied or dissatisfied with the sexual health education provided in schools, and the rest of the results were mixed. And this finding could be contributed to the considerable variation in the context and scope of the sexual health education provided among schools and communities in New Brunswick that Nancy mentioned. Finally, when asked whether they needed more resources to educate their children about sexual health, approximately a third of participants said yes. This was fewer than expected and could be attributed to the high levels of knowledge and comfort in the sample. Nevertheless, there was over 1,800 participants in the study who reported needing more resources, which really does translate to a lot of parents who do need more help with this important matter. In the last section of the survey, participants indicated they needed more sexual health education resources were asked to answer questions about the types of resources they would like to see and how they would like them delivered. And the majority of participants indicated that they could use more resources to support the sexual health education happening in schools. Therefore, it would be helpful if public health resources were consistent with the New Brunswick sexual health education curriculum and were disseminated through schools. Participants also expressed an interest in resources to better understand age-appropriate sexual health education topics to discuss with their children and youth. In terms of the types of resources, most participants indicated that they would like paper-based resources, including brochures, books, and magazines, and they would like to find these resources at schools, healthcare professionals' offices, and pharmacies. Given that brochures were the most commonly selected paper-based resource and are more cost-effective than books or magazines, effort to develop resources should focus on this modality and make them available at the aforementioned locations. The majority of participants also expressed interest in online resources, most commonly websites, interactive tools, videos, and workshops. And participants would like to learn about these resources from schools, healthcare professionals, and social media. Online programs have several advantages, including reduced costs, increased reach, and anonymity. Moreover, these programs can reduce common barriers to accessing resources, including time, transportation, and childcare. Therefore, a sexual health education website would be a cost-effective means to reach many parents. And content on this website could include the popular topics above, including interactive tools, videos, and workshops. And schools, healthcare professionals, and social media could be used to raise awareness of this resource. Finally, approximately half of participants were interested in in-person resources, with workshops being relatively more popular than support groups. Interested individuals expressed a slight preference for weekdays than weekends and would rather attend in the evening than the morning or the afternoon. Schools were the most popular location to hold these workshops, followed by healthcare facilities and libraries. Given the relative disinterest in in-person resources and the cost, time, and effort associated with their delivery, in-person workshops or support groups are unlikely to be an effective use of public health resources. However, if these resources were to be delivered, maximum benefit could be derived from practical workshops delivered on weekday evenings at schools. Lastly, participants were asked to specify which topics that they would like more resources to talk to their children about. The amount of interest varied significantly across topics, ranging from 46% for anal sex to 86% for personal safety. The least common topics were anal sex, correct names for body parts, oral sex, pornography, and vaginal sex. Conversely, participants were more likely to select personal safety, self-esteem, peer pressure, healthy relationships, and consent. And this pattern of results is consistent with previous research, which demonstrated that parents were more likely to discuss safer topics, such as personal safety, than less safe ones, such as sexual pleasure and enjoyment, with the exception of correct names for body parts, which could be due to sufficient knowledge of this topic. Importantly, previous research in this area revealed that topics that are deemed less safe are being discussed too late relative to their children's age. Therefore, these results do not necessarily mean that participants do not need resources on tougher topics, as this could be reflective of the misconception that children are not old enough to discuss these topics. So any resources that are developed should prioritize the topics that parents requested, such as consent and healthy relationships, but should also specify age-appropriate topics and emphasize the importance of discussing age-appropriate sensitive topics before the parents believe that they are needed. Having explored the sexual health education practices of the entire sample of New Brunswick parents, step-parents, and guardians, we then investigated the differences among demographic groups on their levels of knowledge and comfort and their need for resources. And the results of these analyses could be used to inform priority demographic groups that would benefit from the development or adaptation of resources to meet their specific needs. Starting with linguistic differences, English and French participants did not differ significantly on their levels of knowledge or their need for resources. There was a small but significant difference between these groups on comfort, such that French participants reported slightly lower comfort discussing sexual health than their English counterparts. Next, we examined differences among ethnic groups, and only 3 ethnicities had adequate samples to permit statistical comparisons, and those were the European, North American Other, and North American Indigenous. And we found that these groups did not differ on their comfort or their need for resources, but that European participants scored higher on knowledge than North American Other or North American Indigenous ethnicities. Sexual health education resources for Indigenous parents are particularly relevant given the detrimental effects of colonization and the imposition of European concepts of sexuality and gender on Indigenous persons, and the associated sexual health and reproductive challenges facing this population, including higher rates of sexually transmitted infections, pregnancy, and sexual and gender-based violence. Given this context and the differences, albeit small, observed in the present study, the development of resources in collaboration with Indigenous parents would be a worthwhile initiative. Next, we looked at gender differences. Only men and women had sufficient sample sizes to permit statistical comparisons. We found that men and women did not differ on their levels of knowledge, but that men reported lower comfort to discuss sexual health with their children than women. Despite this, women were more likely to report needing resources than men. Therefore, it might be beneficial to develop resources for men to increase their comfort discussing sexual health and to communicate the value of sexual health communication from male parental figures. We also examined differences between sexual orientations. In doing so, we had to group together all participants who selected a sexual orientation other than heterosexual or straight, and that is homosexual, gay, lesbian, bisexual, two-spirited, questioning, and other, to get adequate sample sizes for comparisons. In doing so, we found that non-heterosexual participants reported higher levels of knowledge and comfort than the heterosexual or straight counterparts, but they did not differ on their need for resources. Given the high levels of knowledge and comfort reported by non-heterosexual participants, there would be limited benefit to developing resources specifically for this population. Nevertheless, non-heterosexual parents were equally likely to report needing resources, and as such, it's important to keep this population in mind when developing or adapting new resources to ensure that they are relevant to them as well. Lastly, we examine parental knowledge and comfort in relation to the characteristics of the children in question, specifically the age of the oldest child. And we found that the age of the oldest child was not related to the parents' knowledge or comfort to discuss sexual health with the child. However, there were significant differences when it came to their need for resources. Specifically, parents of children aged 6 to 8 and 9 to 12 were more likely to report needing resources, whereas parents of children aged 13 to 18 were less likely to report needing resources. The higher need for resources among parents of children aged 6 to 12 coincides with the delivery of sexual health education happening in schools. However, parents of children aged 13 to 18 likely still need resources to discuss sexual health with their children. And this could tie into the idea of parents not thinking that their children are ready to discuss riskier topics. Another characteristic of the children we were interested in was whether or not they had diverse learning needs. And we compared parents with or without children with diverse learning needs and found that these parents also do not have any differences in their own levels of knowledge or comfort, but the parents of children with diverse learning needs are more likely to want resources to talk to their children, so there would be benefit of developing resources for these individuals as well. When interpreting these results, it's important to remember that all of these groups did have high levels of knowledge and comfort, and these differences were small in magnitude, but nonetheless, if we're trying to find a place to start, then these would be helpful places. So this is the information that I shared with Nancy and her team based on the results of the survey. And then together we took these and compiled a list of recommendations that Nancy will share with you.
Thanks, Sam. That was great. So our recommendations, number one, and I was quite excited about this because we certainly had a huge partner in schools and school districts in both the Anglophone and Francophone sector across the province in helping to disseminate our survey. And they were really looking forward to the results as well in helping them to in development of new curriculum, updating of curriculum and such. So our number one recommendation was that collaborating with school districts and healthcare staff in developing resources for parents that would complement the sexual health education happening in schools would be certainly a valuable undertaking. Parents reported seeing teachers and healthcare providers as those individuals that they trust in helping to disseminate this information to their children. And those of us who have worked in sexual health for a number of years we certainly felt as well that having those resources that would complement the school-based curriculum and having those be available to parents at the time that this curriculum was being disseminated to their children would really help and provide an opportunity to continue those conversations at home, where we would see some of the spins of the benefits of parents, in being able to discuss their morals and values and such in relation to that information. But just really in continuing that conversation at home, we would see as it being extremely valuable. The second recommendation is that we would share information on age-appropriate topics. And I think some of the results of the literature, some of the results of this study certainly were reflective in that there may be, sometimes you don't know what you don't know. And I think sometimes the parents may have reported, that self-reporting of feeling comfortable, having conversations and having an adequate knowledge base, but maybe not really realizing what is and what isn't appropriate topics to share with children. So that would be something that we feel would really help in the education of parents on, listing topics that are age appropriate for their children, what language to use and how to initiate those conversations in a developmentally appropriate manner. Because as we said earlier, some of those topics are discussed at really too late of a time period when things have already happened or children have already been exposed to certain things that potentially could be detrimental. The third recommendation is that we would look at the development of a primarily online dissemination with supplementary paper resources, because that did still seem to be something that parents would be interested in. So maybe looking at, the formation of a website that could contain interactive tools, videos, and potentially even workshops that would be accessible to all parents across the province, and maybe have paper resources that would go along with that information that could be available through schools or their health providers' offices. Fourth, and this is an exciting one as well, in that we really felt that there could be a co-development of materials between Horizon and Vitalité health networks. The linguistic groups did not differ meaningfully with regard to their needs. Therefore, resources could certainly be co-developed between the two health authorities. There's certainly a huge value in that. Working together just makes sense. And we really want to see a consistency in the terms of other resources and the resources that parents are being provided so that they're consistent throughout the province, which again, definitely makes sense. And the fifth recommendation that we've listed is targeting resources to meet the needs of some of those special populations that Sam referred to. So looking at, and this could include the Indigenous parent population, those parents who identify as men, parents of children in that 6 to 12-year-old age group, and those parents with children of diverse learning needs. And that in particular, that group throughout the years that I've worked in the sexual health program, that was always a group that certainly was asking for more resources. The effects and the size, as Sam said, generally, is small, but nevertheless, they suggest a really good starting point for the development or adaptation of resources that would be valuable to parents, step parents, and guardians across the province of New Brunswick. So in conclusion, from this study, we heard from over 5,400 participants, including representation from a variety of linguistic, ethnic, gender, and sexual orientation groups. And overall, we found that New Brunswick parents and step-parents and guardians reported, they self-reported having high levels of knowledge and comfort to discuss the sexual health topics with their children. However, we feel that there's always room for an improvement, and through the development of and adaptation of sexual health resources, we provided those recommendations that I just reviewed. So moving forward, the public health working group that has been involved in this project, along with hopefully the support unit as well, certainly need to regroup once we have our pandemic work response, once that all begins to settle down, as I know we're all hoping for happening soon. We do definitely need to regroup. And part of the reason for not wanting to share the full report at this point is that we haven't actually been able to share it with our stakeholders and with our other public health counterparts. So we need to report to those partners in health and education and many other community organizations who supported this project from the get-go. And those people also certainly have a vested interest in the follow-through of the proposed recommendations from this report. So that will definitely need to be a collaborative response, having seen, the all hands on deck response to public health emergencies. We know that we're not always available. So having been involved in this gathering of current research and data around the needs of parents in New Brunswick has been certainly an interesting and exciting process. And we, certainly hope to be involved in this piece of work moving forward, but it will definitely need to be a collaborative process through all of those with a vested interest.